It is my pleasure now to introduce three speakers for this session. To my left, Joycelyn Moss. She is the Oncology Specialty Clinical Pharmacist at St. Cloud VA Healthcare System. Next, we have Ann Spengler. She is a Hematology Oncology Clinical Pharmacist at University of Washington Medical Center, Seattle Cancer Care Alliance. And last, we have Rebecca Green. She is a Pharmacy Program Manager, Oncology at Orlando VA Medical Center.
Thank you for that introduction. Anne, Rebecca, and I are very excited to be here, help kicking off this conference today with a great debate on second-line therapy for metastatic renal cell carcinoma, helping you make strategic choices. We have no relevant financial disclosures. Both Rebecca and I work for the VA, but we're not representing the views of the VA today, and we may discuss some investigational use of medications. Our objectives today is we will identify controversies surrounding second-line therapy for metastatic renal cell carcinoma. We'll evaluate the evidence for use of targeted therapy and immunotherapy in the second-line setting, and we'll apply that evidence to select second-line therapy based on patient-specific factors. I think we could all agree it's been a little while since we've actually heard any new and recent emerging data for renal cell carcinoma. Until this past year, and I think many of us may not even see these patients all that often, as many of them are on oral therapies and managing their treatment at home. So I'm going to give you a little bit of background information today and go over some historical second-line data just to get us back up to speed, and then I'll turn it over to Anne and Rebecca to debate the newer second-line data that has come out this past year. An estimated 63,000 cases of renal cell carcinoma were diagnosed in 2016, and this accounts for about 3 to 4% of all cancers. It is twice as commonly diagnosed in males as females, and the peak incidence of age at onset is between 60 and 70 years of age. The 5-year overall survival for metastatic disease has increased to over 10% over the past 10 years, and this is largely due to the introduction of targeted therapies for the treatment of advanced disease. We do have known risk factors that include smoking, hypertension, and obesity, and there is a hereditary component to renal cell carcinoma where if someone has a first-degree relative with renal cell carcinoma, putting them at increased risk. However, we often don't see that a hereditary pattern in the cases that are diagnosed. Renal cell carcinoma is the most solid tumor found within the kidney, accounting for 90% of all renal tumors. It is further subdivided into the clear cell type and non-clear cell type based on the histology of the tumor cell, and this is important for making treatment decisions. You can see the histologies listed there that get kind of lumped into that non-clear cell group. Again, they don't occur as often. The most common renal cell carcinoma is the clear cell type. And about a third of those patients are diagnosed with metastatic disease. So for the talk today, we're going to be focusing on treatments for metastatic clear cell renal cell carcinoma. Whoops. Also important for making treatment decisions is determining the prognosis or risk of the patient's disease. And there are a couple risk models that are out there. The Memorial Sloan Kettering Cancer Center risk model is one that we're probably most familiar with and has been around the longest. This risk model was developed risk factors in patients with metastatic disease during the era of more cytokine-based therapy in the clinical trial setting. You can see the risk factors include poor performance status, a time from diagnosis to treatment of less than 1 year, low hemoglobin, elevated LDH, and a high corrected serum calcium. More recently, we have the IMDC risk model, IMDC standing for the International Metastatic Renal Cell Carcinoma Database Consortium. And this risk model developed and validated risk factors during the era more of targeted treatment. You can see that neutrophil count and platelet count were added to the list of risk factors, and LDH being elevated was removed. For both risk models, though, we then further categorize patients as having favorable, intermediate, or poor risk disease based on the number of risk factors present. In terms of pathogenesis, I think renal cell carcinoma is somewhat unique in the fact that early on, It's one of the few in early cancers where we actually have a known target to stop its growth. We know what makes this cancer tick in terms of cell proliferation and angiogenesis, and that is vascular endothelial growth factor, or VEGF. Renal cell carcinoma is associated with a loss in function of the von Hippel-Lindau tumor suppressor gene. This is indicated by VHL here on the slide. Loss of function of this regulator leads to accumulation of hypoxia-inducible factor, or HIF. This ultimately leads to a cascade and increased transcription of target genes, including VEGF. VEGF then acts on its receptor, and this stimulates a cascade of events, ultimately leading to tumor angiogenesis and formation of blood vessels to feed that tumor. We have a number of targets of treatment then to help block VEGF. We have a group of agents that work on the VEGF receptor on the intracellular domain of that receptor, putting a halt to that cascade of events that lead to angiogenesis. Uniquely, we also have bevacizumab, which binds to circulating VEGF and prevents it from blocking or attaching to its receptor. And then back within the tumor cell, upstream of VEGF production, we have the mammalian target of rapamycin, or mTOR complex. Temsirolimus and everolimus both target and inhibit mTOR, ultimately stopping accumulation of HIF and ultimately VEGF production. In terms of treating metastatic clear cell renal cell carcinoma, we have over 10 therapies that are FDA approved and are listed in NCCN guidelines. And a lot of the agents have data in the first and second line setting. New to the list for second line therapies this past year include cabozantinib, nivolumab, and the combination of lenvatinib and everolimus. You can see that the second-line therapies are listed in no particular order, and some of them do have Category 1 preference or are marked as preferred therapies, but really we don't have a optimized sequence here. I think it's great that we have so many treatment options for patients, but the question really is, what is the best second-line therapy, and even more so, how do we sequence these agents in the third and fourth line setting? I think it's important to also look at the European Association of Urology guidelines. These were also recently updated this past year in their online version. You can see that they do a little bit better job of trying to help us sequence these agents in terms of saying what should be used first line, second line, and even third line by the various columns here, and designating after VEGF therapy and mTOR therapy and so on. But I think it's important to note that we still don't know the best optimal sequence, even with the help of these guidelines here. Also, it should be noted that the EAU guidelines did not include everolimus in combination with lenvatinib in their recent update, and they have not yet updated cabozantinib as second-line therapy based on overall survival, which we will be hearing that we have data for. So I'm going to take you on a bit of a walk down memory lane, and we're going to talk about some historical second-line data to kind of help set the stage and help us evaluate the new data that has come out. I'm going to take you way, way back, and we're going to talk about sorafenib, and I'll get to the point of why. But sorafenib way back was evaluated versus placebo in the TARGET trial, which was a randomized phase 3 trial in patients who had progressed on one systemic therapy. The key is that it had to be cytokine-based therapy, and they could not have been previously exposed to a VEGF pathway inhibitor. You can see that sorafenib did significantly improve progression-free survival over placebo. However, it did not meet the threshold for statistical significance for median overall survival. But it was a pretty robust p-value that they were looking for, and there was crossover allowed from the placebo group into the sorafenib group. I think it's kind of the takeaway from this slide here, even though it's probably not applicable anymore, is that sorafenib really just kind of fell into place as second-line therapy after prior VEGF targeted therapy without a lot of prospective data to support it. So next we'll move on and talk about everolimus. Everolimus was compared in the second-line setting in the RECORD-1 trial to placebo. in patients who had progressed or were intolerant on treatment with sorafenib and or sunitinib. You can see everolimus improved progression-free survival versus placebo at 4.9 months versus 1.9 months in the placebo group. However, it did not statistically improve overall survival. And you can note that the response rate was pretty low in the everolimus group. One thing to consider in the Record 1 trial, patients had actually received prior multiple lines of therapy, so patients were receiving everolimus in even the third and fourth line setting in this trial, which may account for the low response rates. Also, I think it's important to note that at the time of this trial, really the data, while not overwhelming, it established everolimus as a second-line option with a different mechanism of action. A few years later, axitinib emerged with pretty good excitement as a second-generation tyrosine kinase inhibitor targeting the VEGF receptors 1, 2, and 3, also having mild activity against platelet-derived growth factor and c-KIT. It was evaluated in the AXIS trial in a head-to-head comparison with sorafenib. So this was the first trial in the second-line setting that actually paired two targeted agents against each other. And patients had to have progressed on first-line therapy that included VEGF-targeted therapy, temsirolimus, or cytokine therapy. The primary endpoint was median progression-free survival, which you can see axitinib came out on top at 6.7 months versus 4.7 months in the sorafenib group. I think this data shows us that we do continue to see a response and an improvement with continued VEGF receptor inhibition in sequencing these agents, even though the response might be a little less in that next line of therapy. And at this time, sorafenib was the standard of care as a second-line agent. Lastly, we'll talk about the INTERSECT trial. This compared temsirolimus head-to-head with sorafenib. So this was the first time we had data looking at an mTOR inhibitor compared to a VEGF receptor inhibitor in patients who had progressed on first-line sunitinib. So sunitinib was the standard first-line therapy, and again, we have sorafenib as kind of being the standard second-line therapy at the time of this trial. But we really didn't know what the mTOR inhibitor temsirolimus could do in the second-line setting until this trial. Interestingly, sorafenib and temsirolimus, between the two, there was no difference in progression-free survival. 3.9 months versus a couple weeks longer with temsirolimus at 4.3 months. However, there was a statistically significant improvement in overall survival in favor of sorafenib. So this data suggests that there's possibly or maybe an overall survival advantage to continued VEGF blockade in sequencing these agents. Just some other limited prospective second-line data. We have some data for sunitinib after prior sorafenib therapy. Again, keep in mind, back in 2006, these were the only two drugs that were really FDA approved as targeted therapies for renal cell carcinoma. So they often got used sequentially without a lot of data to support that. Pazopanib does have some pretty good data, a phase 2 trial looking at it second line after first line sunitinib or bevacizumab. Response rates were decent at 27%, and the median progression-free survival was 7.5 months. We really have very limited data with bevacizumab, really only phase 2 trials looking at it after cytokine-based therapy. So coming back to our picture, we know targets of treatment, and we know how the treatments work, but what makes them not work or be effective any longer? There is some evidence to suggest that there's mechanisms of resistance, that basically the tumor is figuring out a way to reestablish that angiogenesis procedure or process. And the mechanism of resistance, it does not involve a mutation in a gene encoding for a receptor tyrosine kinase like we see in lung cancer or CML. There have been some mechanisms of resistance that have been identified, and that starts with MET and AXL. MET and AXL is a receptor for another growth factor that works cooperatively with VEGF to help cell tumor invasion and angiogenesis. MET and AXL have been found to be amplified in metastatic renal cell carcinoma and thought to have had a role in developing resistance to VEGF-targeted therapies. Another mechanism back on the tumor cell is the mTOR pathway. It is thought that by blocking the mTOR complex 1 with everolimus or temsirolimus, we see an increase upstream in the PI3K and AKT pathway to compensate for this. That kind of kicks over and stimulates the mTOR complex 2 to ultimately increase levels of HIF and VEGF production. HIF itself can actually be upregulated just simply by blocking VEGF. And then we also see amplification of these non-HIF mediated pro-angiogenic proteins or genes, such as fibroblast growth factor or angiopoietin. And lastly, we might just have ineffective targeting here at the receptor, and that could be due to reduced drug levels, say to a drug interaction per se. So what are some ways to overcome resistance to targeted therapy? Well, we could try to more effectively block the initial target, and one strategy that is maybe not as evidence-based is to increase the dose of the existing agent, although we do have evidence with axitinib in the prescribing information. It does recommend titrating up the dose in absence of side effects. But a more evidence-based approach would probably be to switch to a second-generation VEGF receptor inhibitor. We've already talked about axitinib and its greater potency. Cabozantinib, now we know, is also a potent multi-tyrosine kinase inhibitor that has activity at the VEGF receptor, as well as MET and AXL, which may be important. Another strategy would be to use combination therapies that use different mechanisms of action. So this past year we saw the combination of lenvatinib and everolimus emerge. So now we're combining VEGF blockade and mTOR blockade. A more investigational approach that I think we'll see coming our way down in the future is combining targeted therapy or VEGF targeted therapy with newer immunotherapy. And then the last strategy is to block hyperactive pathways that we just talked about, and this is still investigational as well. So blocking that PI3K mTOR complex 2 pathway or fibroblast growth factor, as we just talked about. So now we've kind of gone over the background and the role of VEGF-targeted therapies in renal cell carcinoma as well as mTOR inhibitors. Now we're going to reintroduce the role of immunotherapy in renal cell carcinoma. We know that renal cell carcinoma is an immune-responsive tumor. We have evidence to suggest that there is spontaneous regression of metastases upon removing that primary tumor. There has been data shown that removing that primary tumor sort of evokes this immune response where they've seen dramatic remissions in lung metastases, so that immune response is helping control the progression of cancer. We've also seen T-cell mediated immune responses documented in renal cell carcinoma. So we know there's this infiltration of T lymphocytes and macrophages in the tumor cell, which is important for the newer immunotherapy agents in terms of their efficacy. And then we also have old data. We know that we get clinical responses to older biological or older immunotherapy drugs like interleukin and interferon, where we can get very durable responses, but at the cost of greater toxicity. So we've seen this wave of immunotherapy come crashing into many different cancers that we treat and deal with, and renal cell carcinoma was included in that wave this past year. We're all familiar with nivolumab as a PD-1 immune checkpoint inhibitor antibody, in which it's blocking that interaction between PD-1 on an activated T cell and PD-ligand 1 on the tumor cell. Ultimately, it's reestablishing that immune anti-tumor response. So that concludes our background information and brings us to our first audience response question. So I'll have you dig out your phones and be ready to answer a question here. We have a patient case. We have a 64-year-old male diagnosed with clear cell carcinoma of the kidney, metastatic to the lung. He has been treated with sunitinib for 11 months, but recent follow-up imaging has indicated disease progression with evidence of new bone metastases. The patient is feeling well, however, and does not report any pain. He does have a past medical history significant for diabetes, hypertension, hyperlipidemia, and hypothyroidism. Labs are good, and you can see his current medications listed there. So, which regimen would you recommend for this patient as second-line therapy? I'll give you a few minutes to respond for a few seconds. All right, so it looks like we might have a good debate on our hands. A, B, C, and D are all correct choices, and actually E is even a correct choice if you look at the guidelines. However, it may be less correct, and we'll get into as to why that is with the newer data. I can see that A, B, C are all choices. So this really helps us set the stage for the debate. So, with the background information and knowing that we have these newer options for second-line therapy, the question is, what treatment would you recommend for second-line therapy? Are you going to stay tried and true with sequencing targeted VEGF tyrosine kinase inhibitors, or are you going to go with that newer era of immunotherapy in your patient? So with that, I'll bring Anne up as she's going to present the data on the targeted VEGF tyrosine kinase inhibitors.
So over the last 12 years, there have been 6 oral VEGF targeted tyrosine kinase inhibitors, FDA approved for the use in patients with renal cell carcinoma. These therapies have been the mainstay of both initial and subsequent treatment for these patients. And because we've had these agents targeting VEGF for use for 12 years, I think providers are pretty familiar with how to use these agents, the toxicities that can occur, and how to manage those toxicities. Of note, 2 of these therapies, cabozantinib and lenvatinib, were FDA approved in the last year in 2016, and these are the therapies that we're going to delve into more in this section in the debate. So I have another audience response question for you. MK is a 52-year-old man with a history of metastatic renal cell carcinoma. He's been treated with sunitinib for the past 18 months, but his recent restaging scans showed progression of multiple bone lesions. MK owns his own business, and he spends much of his time on conference calls or traveling. His past medical history includes hypertension and Crohn's disease, of which he's had 2 exacerbations within the last 6 months, and all of his labs are within normal limits. His current medications include lisinopril, oxycodone, azathioprine, and prednisone. So, this question is, what's the best choice of therapy for MK? I'll close the poll. Okay. I got a lot of people on my side. So I would argue that everolimus probably isn't the best choice of second-line therapy for this particular patient. So I agree with most of you now that we have this new data out that has better response rates than the data for everolimus. Lenvatinib is only approved in combination with everolimus, and it's not approved for monotherapy. And then it comes down to a very patient-specific choice between nivolumab and cabozantinib. And I would argue for this particular patient, due to his need for chronic immune suppression and his prior success with a VEGF-targeted agent, and to kind of fit into his lifestyle, that cabozantinib might be a better choice for him. I've included for you here a summary of select trials in second-line therapy for renal cell carcinoma. So starting from the far left column are the various TKIs, then the trial, the comparator, the number of patients in each group, and then median progression-free and median overall survival outcomes. And this is just so that you can quickly compare those trial outcomes, and then we're going to delve more into the METEOR trial and the lenvatinib and everolimus trial in a few minutes. The first agent we're going to talk about is cabozantinib. It's an oral tyrosine kinase inhibitor that inhibits a multitude of pathways, including MET, the VEGF receptors 1, 2, and 3, and AXL, among others. And these receptor tyrosine kinases are involved in both normal cellular function and pathologic processes like oncogenesis, metastasis, tumor angiogenesis, drug resistance, and maintenance of the tumor microenvironment. It's known that upregulation of MET and AXL occurs in clear cell renal cell carcinoma as a consequence of that von Hippel-Lindau protein dysfunction that was talked about just a little bit ago. And this has been implicated in tumor progression and VEGF tyrosine kinase inhibitor resistance in preclinical studies and is associated with a poor prognosis in renal cell carcinoma. The starting dose of cabozantinib is a single 60 milligram tablet once a day on an empty stomach. And the formulation of cabozantinib that is approved in renal cell carcinoma is the brand name Cabometyx, which is a tablet, while the other formulation that was already on the market, Cometric, that's used for thyroid cancer, is actually a capsule. And these two products are not considered to be bioequivalent due to variations in Cmax that can occur with the different formulations. Cabozantinib is metabolized by cytochrome P453A4, so we need to keep that in mind for potential drug interactions. There is thought to be a connection between MET and VEGF in patients with renal cell carcinoma who have bone metastases. And there's some retrospective data out of Europe that's shown in patients with renal cell carcinoma and bone metastases who were treated with sunitinib, and sunitinib is one of the agents that does not target MET, that those patients actually had poorer outcomes in terms of progression-free and overall survival compared to patients without bone metastases. And this suggests that targeting VEGF alone can result in resistant disease. Another interesting point is that there's data from metastatic castration-resistant prostate cancer that shows that the activity of osteoblasts and osteoclasts is regulated by both MET and VEGF pathways. And there's some additional data that shows that in acquired resistance to VEGF inhibitors, that MET is one of those pathways that's upregulated. So given that additional background information, I hope you can see why targeting VEGF alone might not be enough to keep bone disease at bay in patients with renal cell carcinoma. So the first study that we're going to delve into is the METEOR trial from Dr. Choueiri and colleagues. And this was a phase 3 multi-center randomized open label trial in over 650 adults with clear cell renal cell carcinoma who were previously treated with at least one VEGF targeted therapy and had disease progression during or within 6 months of their last treatment. Patients were randomized in a 1-to-1 fashion to treatment with cabozantinib 60 milligrams by mouth daily or to everolimus 10 milligrams by mouth daily, which was considered to be a second-line standard treatment option. The primary endpoint here was progression-free survival, assessed by RECIST criteria, and secondary endpoints included overall survival, overall response rate, and safety. Cabozantinib was found to have a median progression-free survival of 7.4 months compared to 3.9 months with everolimus, which was an improvement of about 3.5 months. The median overall survival was 21.4 months in the cabozantinib arm compared to 16.5 months in the everolimus arm, which was an improvement of close to 5 months with cabozantinib. And this translated to a 34% reduction in the risk of death in patients treated with cabozantinib. The overall response rate was 17% in the cabozantinib arm versus 3% in the everolimus arm, and all of these results were statistically significant. Patients in the cabozantinib arm were able to stay on treatment a little over 3 months longer compared to everolimus. About 60% of patients in the cabozantinib arm required dose reductions, and the average daily dose was actually closer to the first dose reduction level of 40 milligrams. Patients discontinued treatment at similar rates in both arms of the study. The toxicities of cabozantinib are similar to what we usually expect with other VEGF-targeted agents. So we saw diarrhea, fatigue, palmar-plantar erythrodysesthesia, hypertension, and there was not a high degree of bone marrow suppression, which is a toxicity that we might see with some of our other VEGF-targeted agents like sunitinib. The only bone marrow toxicity that we had seen in this study was anemia, and that occurred at rates that were lower than what we have seen with other agents. So I mentioned earlier that bone metastases are associated with a poor prognosis in renal cell carcinoma, and one of the benefits of cabozantinib may be that it targets bone mets more specifically. So in the top table here is data from a pre-specified subgroup analysis of the METEOR trial that explored outcomes in patients stratified by absence or presence of bone mets. And this shows that in the subgroup of patients with bone mets, that both overall survival and progression-free survival outcomes appeared to be improved to a greater degree in those patients who had bone mets compared to those who didn't have bone mets when they were treated with cabozantinib. In the second table here is data from ASCO in 2016. That was an analysis done by Escudier and colleagues, and they re-looked at patients from the METEOR trial and subdivided them. And in the cabozantinib group in patients with bone metastases, the median progression-free survival was similar to what was seen in the overall population in the range of 7 months, versus in the everolimus group in patients with bone mets, the median progression-free survival was actually lower, so 2.7 months in patients with bone mets compared to almost 4 months in the overall population. As for other bone-related endpoints, response seen on bone scan was increased in the cabozantinib group, and patients in the cabozantinib group had fewer skeletal-related events after randomization. Lenvatinib is the second oral VEGF-targeted TKI we're going to discuss today, and that received a breakthrough therapy designation from the FDA in 2016. It again targets multiple VEGF receptors as well as the fibroblast growth factor receptor, platelet-derived growth factor alpha, and some additional targets. And these are involved in normal cellular function and pathogenic processes such as oncogenesis, metastasis, tumor angiogenesis, and maintenance of the tumor microenvironment. Lenvatinib is dosed at 18 milligrams by mouth once a day, which is a combination of one 10 milligram tablet and two 4 milligram tablets. Its use is only improved in combination with everolimus, which is used at a lower starting dose of 5 milligrams. And as with other VEGF-targeted agents, metabolism occurs via CYP3A, so there's lots of potential for drug interactions with this one as well. The next study we're going to discuss was published in 2015 by Dr. Motzer and colleagues. It was a phase 2 multi-center randomized open-label trial in about 150 adults with clear cell renal cell carcinoma who had previously been treated with at least one VEGF-targeted therapy and had disease progression during or within 6 months of their last treatment. Patients were randomized in a 1-to-1-to-1 fashion to combination therapy with lenvatinib 18 milligrams and everolimus 5 milligrams daily, lenvatinib 24 milligrams once a day, and if you have the printed handout from HOPA, you should correct that dosing there, or to everolimus 10 milligrams once a day. The primary endpoint was progression-free survival, and secondary endpoints included overall survival, overall response rate, and safety. The median progression-free survival was extended to 14.6 months with combination therapy, which was about double compared to the monotherapy comparator arms. There was not a significant difference between lenvatinib and everolimus monotherapy. With combination therapy, the median overall survival was 25.5 months, which was an improvement of about 6 months compared to the monotherapy arm. And combination therapy also had the highest overall response rate that we've seen at 43% of patients. Patients were able to stay on lenvatinib or combination therapy for about 7.5 months, which was longer compared to the 4 months on everolimus therapy. However, dose reductions were very common, and patients were more likely to discontinue their therapy in the lenvatinib-containing arms of this trial. The increases in progression-free overall survival and response rate were accompanied by increased rates of toxicities. Again, as we would expect in the lenvatinib-containing arms, patients experienced toxicities related to VEGF inhibitors like diarrhea, fatigue, hypertension, and skin changes. And patients in the combination therapy arm also had those additional toxicities that we would expect from everolimus, like increased cholesterol, peripheral edema, and stomatitis. And again, hematologic toxicity was not a commonly reported side effect in this trial. So in summary, based on all of the data that I've just presented to you, both cabozantinib and combination therapy with lenvatinib everolimus have shown the benefits of increased progression-free and overall survival compared to everolimus alone. The toxicity profiles are what we would expect with VEGF inhibitors, with the exception maybe of lower rates of hematologic toxicities. And although there are significant toxicities associated with these agents, I want you to remember that these drugs have been in use for 12 years, so I think providers really understand how to recognize and treat those toxicities. And patients are often using a VEGF-targeted therapy in their first line of treatment, so those patients are also familiar with what those toxicities are as well. There may be some additional benefit for using cabozantinib in patients with bone metastases due to its ability to target both MET and VEGF. And the lenvatinib everolimus combination therapy had the highest rates of overall response at 43%, but providers would really need to weigh that against the potential that potential benefit against the increased toxicities that patients experience. So now I'll turn it over to Rebecca for immunotherapy.
All right, so with that, we'll come to our next audience response question. So we have TS. He's a 68-year-old male who has a history of metastatic renal cell carcinoma. He has received sunitinib for the past 14 months, but recent restaging scans showed progression of 2 lung lesions. TS is retired, but he helps take care of his grandchildren. He wishes for further therapy, but he wants therapy that has limited toxicities and interference with his quality of life. His past medical history is significant for osteoarthritis and hypertension. His labs are all within normal limits, and you can see his current medications listed. So which is the best choice of therapy for TS? A, nivolumab, B, cabozantinib, C, temsirolimus, or D, everolimus? Give a few more seconds for those last-minute answers. Okay, and we'll close the poll. Okay, so the majority of people responding chose nivolumab, and I would agree that for TS, this is likely the best option for this patient. I think throughout the talk, you've heard why everolimus is becoming less of a optimal option in the second-line therapy. Temsirolimus, again, if you remember from the NCCN guidelines, is generally recommended in patients who have poor prognostic factors, and TS did not have any of those that were presented. So it really comes down to a choice between nivolumab and cabozantinib, and I hope over the next few minutes I will show you why I feel like nivolumab is the better option for patients who are very concerned about their quality of life and toxicities from therapy. So as previously mentioned, renal cell carcinoma is an immunogenic tumor. Historically, we have treated this disease with varying levels of success with cytokine-based immunotherapy. So pursuing additional targets within the immune system has been an area of active research. So one of these areas to target includes immune checkpoints. Normally, the immune system recognizes tumor-specific antigens, which activates T-cell-mediated killing of tumor cells. The programmed death or PD pathway is a pathway that actually prevents overactivation of the immune response. PD-1 receptors are expressed on activated T cells, and PD ligand 1 and 2 are expressed on immune cells as well as tumor cells. And the interaction between the receptor and the ligands inactivates T cells and suppresses the immune response. And there's actually been some data to show that patients who overexpress PD-L1 in renal cell carcinoma have poor prognosis. So PD-1 inhibitors, which we'll be talking about nivolumab today, block the interaction between the ligand and the receptor, and this leads to restored anti-tumor immunity and T-cell mediated killing of tumor cells. So again, nivolumab is the agent we'll be discussing, and it was approved for advanced or metastatic renal cell carcinoma in patients who had received previous anti-angiogenic therapy. Its initial approval came in November of 2015 at a dose of 3 milligrams per kilo every 2 weeks. And in September of last year, the dosing was updated to a flat dose of 240 milligrams every 2 weeks. This updated dosing was based on population kinetic simulations that showed that there really was no difference in the exposure to the drug, and it was very likely that there was no clinically significant difference dosing at 3 milligrams per kilo versus a fixed dose of 240, and so therefore the drug indication was changed. There's no dosing adjustments with renal or hepatic impairment, but do note that studies in patients with moderate or severe hepatic impairment have not been conducted. The other reason that the drug was changed to a fixed dose was because there is really no dose response with this medication, and that was shown in a phase 2 trial that was assessing dose response. They enrolled almost 170 patients, and doses increased from 0.3 milligrams per kilo every 3 weeks to 10 milligrams per kilo every 3 weeks. The primary endpoint was progression-free survival, and there was no significant difference in progression-free survival. In addition, overall response rates in these patients range from about 20 to 22%, and the median overall survival ranged from about 18 to 25 months. So the Checkmate 25 trial was published in 2015, and this trial was a phase 3 randomized trial of patients with advanced clear cell renal cell carcinoma who had had 1 or 2 previous anti-angiogenic therapies. They excluded patients who had untreated CNS metastases and also patients who required greater than 10 milligrams of prednisone equivalents per day. Patients were then stratified for their region, their prognostic risk group, as well as the number of previous treatments. And they were randomized in a 1-to-1 fashion to nivolumab 3 milligrams per kilo every 2 weeks or everolimus 10 milligrams daily. The primary endpoint was overall survival, and the secondary endpoints included overall response rate, progression-free survival, an association between overall survival and tumor expression of PD-L1, as well as safety. So looking at some of the baseline characteristics of patients in this trial, 90% of the patients had a previous nephrectomy in both groups. The median time from diagnosis to randomization was about 31 months in both groups, and almost 3/4 of the patients had only received 1 previous line of anti-angiogenic therapy, with the most common therapies being sunitinib or pazopanib. So the trial was actually stopped early at an interim analysis in July of 2015 due to the Independent Data Monitoring Committee finding that the trial had met its primary endpoint of a significant improvement in overall survival. And there was about a 5.5-month improvement in overall survival with nivolumab as compared to everolimus. So in everolimus, the overall survival was about 19.5 months versus 25 months in the nivolumab group, and this was significantly different. When they looked at some of the other endpoints, the median progression-free survival was not different between the two groups. And this is not terribly surprising, as we do know that there is the pseudo-progression phenomenon that's being seen with these immune checkpoint inhibitors. So oftentimes progression-free survival is not different with these drugs. Additionally, the median time to response was reported and was similar between the two groups at about 3.5 months. The median duration of response was also similar between the two groups at around 12 months. The other area where there was a significant difference was in the objective response rate, and 1/4 of the patients receiving nivolumab had an objective response versus only about 5% in the everolimus group. Looking at the tolerability of nivolumab, this table list some of those endpoints, including the median duration of treatment. It was a little bit longer in the nivolumab group at 5.5 months versus 3.7 months with everolimus. Dose reductions were not allowed in the nivolumab group, but patients could have dose delays. So about 50% of patients had a dose delay in the nivolumab group versus almost 2/3 of patients in the everolimus group either had dose delays or dose reductions. When looking at our treatment-related adverse events of any grade, those were significant in both treatment arms. So 80% of the nivolumab patients had some sort of treatment-related adverse event. Almost 90% in the everolimus group had treatment-related adverse events. When we break it down to those adverse events that are more significant and can affect our ability to continue treating a patient, the grade 3 and 4 treatment adverse events, I think this is where a difference starts to really come out, in that 19% of patients in the nivolumab group had grade 3 or 4 treatment related adverse events versus almost 40% in the everolimus group. And those that actually required discontinuation of treatment was less than 10% in the nivolumab group, but over 10% in the everolimus group. Breaking down these toxicities a little bit more, what we know is that the most common any grade toxicity in the nivolumab group were fatigue, nausea, and pruritus. The most commonly seen toxicities in everolimus were fatigue, anemia, and then also stomatitis, which I'll show in a different slide. Looking at grade 3 or 4, so again, fatigue and anemia were the most common ones seen in the nivolumab group. Grade 3 or 4 anemia was much more common with everolimus than with nivolumab. Diarrhea and rash were seen with nivolumab, but again, they were much more common at any grade with everolimus. Looking at additional toxicities, such as peripheral edema, pneumonitis, stomatitis, again, looking at these rates, they occurred at a much higher rate in the everolimus for any grade as well as grade 3 and 4. So I think these slides show that the nivolumab patients tended to have much fewer toxicities associated with therapy than those who received everolimus. One of the things that was not discussed extensively in the checkpoint trial, but is important to mention, are the immune-related adverse events that occur with these PD-1 inhibitors. So as we mentioned, the PD-1 inhibitors, the loss of T-cell inhibition from these PD-L1 inhibitors actually increase your immune response and can lead to impaired self-tolerance. So theoretically, these immune-mediated adverse events can affect any organ, but most commonly what we see is that they affect the GI tract, they can affect dermatologic areas, as well as endocrine and hepatic. There were fairly low rates in the CheckMate trial, and I think all of us are becoming more and more familiar with these toxicities the more these agents are being used. So it's just important to make sure that patients, caregivers, as well as healthcare providers are educated on these agents and these immune-mediated toxicities and how to actually treat them with immunosuppression. One of the other things the CheckMate trial did was try to tease out what patients are going to benefit from nivolumab therapy. And so they looked at PD-L1 expression in association with overall survival. And of the patients they were able to determine PD-L1 expression, about 3/4 of them had less than 1% PD-L1 expression. In that patient population, the median overall survival for nivolumab was about 27 months versus 21 months in the everolimus group. 1/4 of the patients expressed PD-L1 or had 1% or greater expression. The median overall survival in the nivolumab group for that subset of patients was about 22 months versus 18 months in the everolimus group. So what this showed is that PD-L1 inhibition with PD-1 inhibition with nivolumab is effective across the board in patients who have metastatic renal cell carcinoma. It's not predictive of response. However, PD-L1 expression may be associated with a poor prognosis in these patients. The Checkmate trial also evaluated quality of life, and they did this using the functional assessment of cancer therapy kidney symptom index disease-related symptoms tool. And this tool evaluates 9 different disease-specific areas, including things like fatigue, weight loss, pain, with a questionnaire. And the patients are given a score anywhere from 0 to 36, with 36 being no symptoms from their disease, so higher scores indicating a better quality of life. At baseline, in both groups, the median score was 31, and throughout the course of the trial, the median change in the quality of life increased for nivolumab and was significantly different from everolimus at all the time points when it was evaluated. So over the course of the trial, nivolumab increased about 3 points, whereas everolimus decreased quality of life scores by about 3 points. So to summarize the Checkmate trial, there was a significant improvement in overall survival that led to the stoppage of the trial early. There was no significant difference in progression-free survival, and again, this is not necessarily unexpected due to the pseudo-progression that we're seeing with these agents. This has actually led to some new response criteria to be developed, the immune-related response criteria, that may be more appropriate to use in trials moving forward of these immune therapies as opposed to our traditional RECIST criteria. PD-L1 expression is associated with a poor prognosis. However, it is not a predictor of response for nivolumab in these patients. Therefore, nivolumab is an option for any patient with metastatic renal cell carcinoma in the second or further line therapies. And again, patients who received nivolumab compared to everolimus experienced a significantly lower incidence of any grade or grade 3 or 4 toxicities. They had very similar response times to everolimus, but an improved quality of life and a very low rate of discontinuation for adverse events. And so with that, I will bring Anne for her rebuttal.
So there are benefits to using TKI-based therapy compared to immunotherapy. And while there wasn't specific time to response data that was reported for cabozantinib in the METEOR trial, it would be expected that the time to response would be similar to our other VEGF TKIs. The data that we do have is for sunitinib, and it had a median time to response of 10.6 weeks, and that's compared to the 15 or so weeks that was seen with nivolumab. So in patients who need a response more quickly to get their disease under control or whose disease progressed rapidly on prior therapy, another VEGF-targeted therapy should be the treatment of choice over an immune therapy. Secondly, patients would be able to do their TKI treatment at home rather than come in for an infusion every 2 weeks, which might be more conducive to certain patients' lifestyles. The immune therapy trial specifically excluded patients with concomitant disease states, like autoimmune diseases requiring significant amounts of glucocorticoids, patients with chronic viral infections, and transplant patients. And while the data for the use of immunotherapies in those special populations continues to emerge, it's still really limited at this time. There are also some other concomitant disease states like type 1 diabetes, for example, where we should be weighing the risk-benefit of potentially having to manage an immune-related toxicity with steroids in that particular patient, and the potential of having a difficult time managing that patient's underlying condition. I would also argue that since these VEGF-targeted treatments have been around since the early 2000s, providers in general, including those in a community setting, are more aware of what those common toxicities are with these agents, like diarrhea, hypertension, and hand-foot syndrome, and how to actually manage those toxicities. And while our oncologists who are prescribing these therapies are becoming more familiar with the management of immune-related toxicities, since they're so new to our armamentarium for treatment, I would argue that overall awareness of those toxicities and the management of immune-related adverse events hasn't really trickled out to our other members of the healthcare system. And as was mentioned, immune-related adverse events can essentially occur in any organ system. And while in general these side effects occur in a low incidence compared to targeted therapy, when toxicity does occur, it can be really severe and life-threatening for patients. And if not adequately managed early, patients can suffer for that. The other aspect of these immune-related adverse events is that these toxicities are often delayed, occurring weeks to months into their treatment regimen, so they might not be on the forefront of people's minds as being related to their immune therapy. With immune therapy being relatively new, it's also taken time to develop standards for the management of immune-related adverse events, and at this time, there's really only standards for initial management, and if a patient fails initial management, there's not really good standards for what to do in the second-line setting. And while that kind of initial management information has become more widely available, I think there's still a lot of room for error in the management of patients who experience immune-related toxicity and kind of an overall awareness of what those immune-related toxicities are. So just in practice, I've seen a patient receive a methylprednisolone dose pack instead of high-dose steroids. I've seen patients who've been tapered off of their steroids too quickly and have immediate recurrence of their side effects. And I've also seen a patient who returned home to a rural area in between treatments and ended up having diarrhea so severe he needed to be admitted into a local hospital. And it's not really clear if that outside hospital even had this information that he was being treated with an immune therapy. And that particular patient was tested for C. diff 3 times before anybody called his oncologist to see if it could be related to his treatment. And I think that all 3 of those examples just illustrate how side effect management with immune therapies hasn't really been disseminated to the entirety of our medical system, and the provider who's managing toxicity or managing giving these agents really needs to be aware of what's going on with their patients. And also so that patients know what these potential side effects are and that they can be delayed so that they can also make sure that they're reporting anything that's happening so that they can be intervened on early. And then lastly, since we don't have any head-to-head trials that compare TKIs and immunotherapy in the second-line setting, I think it's important to keep in mind that we can't really accurately compare specific data across these trials, and we can really only make generalizations. So I've created a table here for what some of those comparisons are. And in the nivolumab and cabozantinib trials, about 70% of patients were in the true second-line setting. In the lenvatinib everolimus trial, every patient that was included was actually a true second-line patient. In comparing the disease status of patients based on the MSK risk group criteria, the patients that were in the nivolumab and cabozantinib groups were more heavily weighted toward the good and intermediate risk groups, whereas the patients that were in the lenvatinib everolimus group were more weighted toward the intermediate and poor risk groups. And then in terms of overall survival, all of these agents had somewhere in the range of a 20-month overall survival benefit for patients. And then with the exception of the lenvatinib everolimus combination therapy, the treatment discontinuation rates were all less than 10%. So I would argue that the treatment with any of these therapies in the second-line setting is a reasonable option, and that is really where making a patient-specific choice is going to come into play. I will turn it over to Rebecca for rebuttal.
Okay, so we can't compare cabozantinib and nivolumab because they have not been compared head to head. But I think it is important to kind of look at them side by side and get an idea of where there are some similarities and where there are some differences. So if we look at the METEOR trial versus the CheckMate 25 trial, you can see that both included patients with clear cell component. They both included patients who had multiple prior therapies. Again, about 70% had only received one prior therapy. Both of the trials allowed for treatment continuation after progressive disease if the patients were having a clinical benefit and acceptable toxicities. Where some of the differences start to come out are with the key exclusion criteria, including the glucocorticoid use in the patients receiving nivolumab. In the METEOR trial, it was listed as uncontrolled clinically significant illness. And again, another difference comes with the route of administration. So there is the ease of PO administration for cabozantinib versus IV therapy. However, there may be issues with adherence to therapy. There also may be some differences in the cost to the patient of these therapies depending on their insurance and copay situation. So what else can we use to help guide our decision? Well, there are several factors that we can take into consideration. So duration of treatment, speed of response, the overall survival, the tolerability of the therapy, and finally the quality of life that can be achieved on these particular therapies. So again, looking at these trials side by side, we can see that both cabozantinib and nivolumab had a longer duration of therapy as compared to everolimus. Looking at the speed of response, cabozantinib, again, was not reported, so we can make some assumptions that it may be similar to other TKIs, but we actually don't have that data to confirm what the time to response will be for cabozantinib. We know that with nivolumab, it is similar to everolimus, which in the past has been a standard second-line therapy for patients with renal cell carcinoma. Looking at the objective response rates, both cabozantinib and everolimus had improved overall response in comparison to everolimus. However, I would argue that the degree of difference between everolimus and nivolumab seems to be a little bit different than that between everolimus and cabozantinib. Both of the agents we now know do improve overall survival, again, in comparison to everolimus. So, they both will improve overall survival. So where I think the difference really starts to come in is that tolerability of therapy. So we've talked about this quite a bit, but the area to bring your attention to, again, is that grade 3 or 4 toxicity. Only 20% of patients receiving nivolumab had grade 3 or 4 toxicity versus 70% of patients who received cabozantinib. And there were more dose reductions with cabozantinib than even everolimus in the METEOR trial. So I think this is important to keep in mind. And yes, the immunotherapies are new, and providers and patients may not be as familiar with these immune-mediated toxicities that can occur with nivolumab. Keep in mind that it's a low rate of immune-mediated toxicities that occur. And I think the more and more that we see these drugs being used, not just in renal cell, but in many different types of tumors, people and providers and healthcare systems are going to be more familiar with these toxicities and aware of how to treat them. I think this also goes to the point that we really need to educate our patients and the patients' caregivers on what these toxicities are, how to recognize them, and have them be their own advocate if they do need to go into a rural hospital as far as what may be the cause of their side effects. And finally, with quality of life, we know that it was improved with nivolumab as compared to everolimus, and we currently don't know with cabozantinib what its effects will be on quality of life for this patient population. So again, to summarize, nivolumab has a novel immune-mediated mechanism of action. It appears that it may be better tolerated than cabozantinib. We do know that PD-L1 expression is not a predictor of response, and therefore it is an appropriate agent at this time and any patient in the second-line setting. And again, the quality of life has been improved on nivolumab, as opposed to cabozantinib, where we don't have that information. And so with that, I'll bring Jocelyn back up.
All right, you've heard both sides of the debate, and I don't know about you, but I'm glad it didn't get too rowdy up here. But I do want to present some last-minute future considerations and conclusions. You will note that cost comparison was not an argument made today on either sides of the debate, because the cost of the agents is pretty similar amongst all of them, with the exception of the combination of lenvatinib and everolimus, which comes with a little steeper price tag. I think biomarkers is an area that will continue to evolve and emerge as a future consideration. We know in terms of immune biomarkers, PD-L1 continues to be a robust biomarker, but still hasn't offered much in terms of being able to predict benefit or response. In terms of other development of biomarkers to really help personalize treatment, looking at measuring possibly MET, mTOR, and maybe even the VEGF receptor itself. Data is going to continue to emerge, so I think it's important to consider how this data will kind of shift the lines of therapy. This past year, we had the CABOSUN trial be presented at the ESMO annual meeting in 2016 in abstract form, and has since been published. The CABOSUN trial looked at comparing cabozantinib to sunitinib in the first-line setting in a randomized phase 2 trial. So patients were included with untreated metastatic clear cell renal cell carcinoma, and they were included if they had intermediate and poor risk disease. The primary endpoint was progression-free survival, and you can see that cabozantinib came out ahead of standard first-line sunitinib in terms of progression-free survival at 8.2 months versus 5.6 months in the sunitinib group. Also note that overall response rates were significantly high, or were higher. P-value was not reported as well in the cabozantinib group. But do note that grade 3 or higher adverse events occurred in more than 70% of patients in both treatment arms, and 16 patients actually stopped treatment due to toxicity in each arm. So therapy was not very well tolerated. But if cabozantinib does emerge as a first-line option for this particular patient population, then it would take it out of the running and second-line therapy and potentially shift sunitinib into that second-line role without a lot of data, again, to support that. I also just want to lastly point out that the response rates are pretty low in the sunitinib group compared to what we've seen in other first-line trials, where response rates are closer to 30%. But again, in those trials, they had more of an intermediate favorable patient population versus this study, which only looked at intermediate and poor risk patients. Other trials to keep your eye on for future consideration is a Checkmate 214 trial, which is a phase 2 trial that's ongoing, looking at combining immunotherapies, so nivolumab in combination with ipilimumab versus sunitinib in the first-line setting. So potentially could take nivolumab out of that second-line role. And then the Checkmate 016 trial is a phase 1 trial that's looking at combining nivolumab in combination with sunitinib or pazopanib in that second-line setting. And there has been reports of encouraging anti-tumor activity and manageable safety. So more to come there. So are we any closer to determining an optimal sequence? Do you think there's a front runner in terms of which agent you'd choose for second-line therapy? I think as you I've gathered throughout your responses to the audience response questions, you really have caught on that it's more about making a strategic choice for your individual patient. In terms of the direction of immunotherapy, things to consider is we know we have improved overall survival, well-tolerated therapy, quality of life is maintained, but things to consider is that patient does have to come in every 2 weeks for an infusion. We do have to consider management of immune-mediated adverse effects of both Anne and Rebecca have discussed. And then also consider if, the patient does have a comorbid autoimmune disease that would require immunosuppressive therapy. Again, as was mentioned, I think data is emerging that this may not be an absolute contraindication, but for the time being, it's consideration to not jeopardize efficacy. And then also think about, is that patient eligible for, or is there a clinical trial available? Because these immunotherapies are going to continue to be heavily looked at in the clinical trial setting. So if you have a patient that might be eligible for one, you might not want to use nivolumab right away in the second line setting if we can get them in to receive nivolumab in a clinical trial setting. Then in the direction of targeted therapy, we see the benefits of response time. It is an oral therapy that patients can take at home, and we do have overall survival data with cabozantinib. But again, considerations are adherence, which will continue to be a concern in patients taking oral therapies. There are a ton of drug interactions, and we've talked about the dose-limiting side effects. But also consider other comorbid illnesses that side effects could affect in terms of hypertension, hypothyroidism, and diabetes. So, to conclude, we'll bring it full circle and bring it back to that first initial patient case where we have our 64-year-old male who had failed first-line sunitinib and now has evidence of new bone metastases. Patient is feeling well, not reporting any pain. You can see his past medical history there. Again, labs are good, and his medication list. So, to re-poll the audience and see who won the debate, so to speak, which regimen would you recommend for this patient as second-line therapy? Ooh. A pretty even split. I don't know. Let's see. Nivolumab did come out on top. Both answers would be correct, could be correct. Cabozantinib based on the evidence in bone metastases. And nivolumab in terms of maybe that patient needs a break from tyrosine kinase inhibitor side effects. But both agents do have that new endpoint of overall survival in metastatic renal cell carcinoma. So good job. Thank you for coming to attend our talk today. We hoped we helped you make a strategic choice in terms of second-line therapy. And at this time, we'll open it up for questions.